Good evening, everyone. I welcome you all from Foxy Medical Disorders in Pregnancy Committee for a very interesting and the much talked about topic in these times, that is on COVID-19 and COVID-19 positive mothers and babies. We are all the time bothered about the maternal transmission, the neonatal outcome, and we have delivered so many COVID positive mothers. And definitely, even the patients are having so much dilemma in their mind whether to get pregnant during COVID. Will the pregnancy be a normal pregnancy? Will the COVID have effect on the baby, and what will be the outcome later on? So all these dilemmas are going to get demystified, and we have very eminent speakers. We have none other than Dr. Nozer Sheriar, who will be talking about the maternal aspect of COVID-19. Then Dr. Taslima, who will be talking about the neonatal outcome, and Dr. Gunjan regarding the critical care. And I would really like to thank all the faculties, all these eminent faculties who have accepted the invitation to be part of this program. And I extend my gratitude to Foxy President Dr. Alpesh Gandhi, Jaideep Tang, Secretary General, Foxy, Dr. Atul Ganatra, Vice President in charge, and today's sponsor, the MCure Pharma and the team Science Integra, TOG platform, for bringing us live together. So without wasting any time, I would like to hand over to the moderator for today, Dr. Niranjan Chavan. And Dr. Niranjan Chavan, we know he is a professor and unit chief at LTMG at Sion Hospital and has been actively working during this COVID time and has managed so many COVID positive patients. In fact, Sion Hospital was the first hospital in Mumbai to report the highest number of OBGYN COVID positive patients. And he is also the joint treasurer elect of Foxy, national coordinator for the Foxy Medical Disorders in Pregnancy Committee, and vice president of Mumbai Obstetrics and Gynec Society. Over to you, Dr. Niranjan Chavan, to take over the proceedings.
Thank you, Dr. Komal Chavan. And today is 27th of February. We are again in the peak of the second wave of COVID-19 pandemic. Ironically, the cases have been increased. What 4 months ago, it has doubled now. And there are recent reports that in the city of Mumbai and in the city of Amravati, in Latur, in Ambezogai, and other interior parts of Maharashtra, then state of Delhi, in Kerala, and in Punjab, Andhra Pradesh, the cases have increased rapidly. There are also new mutations which have occurred, and this mutation virus is seen to have a super fast traveling time, and it also affects not only the senior elders and mothers but also a younger population. So we are more worried, and in spite of the best efforts by the Ministry of Health, Family Welfare, the public and the private hospitals, the numbers have increased. To share you briefly, can I have the next slide, please? This is the latest report what is happening in Maharashtra. To take an example, we have crossed more than 8,300 new coronavirus cases, and in the city of Mumbai itself, we have got more than 1,100 cases being reported till 6 p.m. yesterday evening. So I'm sure we are all worried, and we are going to go through this all together, all of us, as an obstetrician, as a gynecologist, as a neonatologist, and tide over this crisis. And today, it's a very important day for me that I have esteemed speakers who are going to share their experience of managing COVID cases in the pandemic time, and also what they would advise and guide us to be careful and how to go about to manage them. So I would invite now my first speaker, and that's none other than Dr. Nozer Sheriar. I can say he is an epitome and a Bible of knowledge, and I had the opportunity to be his student in Wadia Maternity Hospital at St. GS Medical College, and the way he conducts himself, and he is so graceful. I can say he is also a celebrity obstetrician. Much more than that, he has been a part of Mumbai Obstetric Gynec Society as its president in 2011, and he was also the Secretary General spearheading the Federation of Obstetrics and Gynecological Society of India, having 38,000 members. His field of interest is MTP, contraception, obstetrics, instrumental deliveries. I can go on and on. And he is presently representing India, our own country, as a member of the Technical Advisory Group WHO Southeast Asian region. He has also been a member board of the Good Matcher Institute, IPAS, and C3. He is the only Indian to be the scientific chair of the FIGO, and it was conducted very nicely by him. Welcome, sir, for your presentation on the COVID positive mother and its obstetric management. I know, sir, you have been very busy and your schedule is too tight, but in spite of that, you have been very kind enough to impart knowledge and wisdom to all of us. Thank you so much for being there with us today.
Thank you, Niranjan. Niranjan, Komal, my co-panelists. It's a pleasure to be here today. If I could just share my screen. Uh, so I have a confession to make, Niranjan, if I may, on your behalf. When Niranjan asked me to give this talk, I said, Niranjan, there are so many people more qualified than me. People like you who have worked in the public hospitals, who managed probably many more cases than I have. But Niranjan was very clear. He wanted a general OBGYN's perspective on managing this particular disease during pregnancy. And well, all I can say is in a private practice in Mumbai, to date, I've had 34 pregnant women who had COVID, either during pregnancy, when they were delivering in labor, and some of them post-delivery. And you know, every patient teaches you a lot of things. I love the quotation which says that experience is a hard teacher. It gives you the examination first and the lesson afterwards. So we continue to live under the COVID cloud. And it bothers me sometimes when people underplay the significance of this pandemic, because it's not something that's happened to the world for the first time in this century. In fact, this is the third deadly outbreak due to a coronavirus. Let's not forget SARS in 2003. Let's not forget MERS in 2012. And we have all lived through the H1N1 pandemic, which for the obstetrician was quite distressing because a number of the mortalities were actually women who were pregnant. We cannot take COVID lightly because to date, till this month, it has taken, I keep telling my patients, don't be negligent. Remember that this disease has taken 2.5 million lives worldwide, and it's not spared any region. So Arundhati Roy has said historically pandemics have forced humans to break with the past and imagine the world anew. This one is no difference. It is a portal between, it's a gateway between one world and the next. And let's see the pandemic that way. And let's see, we've learned so much. We've done things differently. And what can we carry forward? A lot of good things have come from changes in practice. What can we do to carry this forward into the future practice? Well, firstly, delivering patients under the COVID cloud is probably the new normal for this most essential service. Right from the beginning of the pandemic, we struggled. We struggled initially to have authorities understand obstetrics cannot wait. All elective work came to a standstill. A lot of work came to a standstill. Hospitals were closed. OBGYN departments were shut down because we overreacted. But a woman who's going to deliver cannot wait. And I had to keep reminding them that each year each month, about 2.2 million women deliver in our country. So let's see what this brings to the woman and to the practitioner. Well, the first thing is women were scared, they were petrified, and there was something called as the worried well. The worried well are healthy persons with less severe problems, with intermittent concerns about their health. They don't have the disease, but the fear, the paranoia can really make life complicated and create problems from them. What can we do as clinicians? Well, the first thing is don't dismiss or turn away any patient or dismiss a problem. Make them feel understood, provide them with authentic clinical information. What I have told my patients from the start of the pandemic is there's no way you can take things lightly. But as a woman, as an obstetrician, I can tell you that COVID has largely been kind to pregnant women. 27 million births in India in the last 1 year since the pandemic, and thankfully, we have not seen any big contribution to maternal mortality. It does not seem to cause birth defects. We know what other viral infections such as rubella, varicella do. It does not seem to really put the mother at risk, though I must say that there have been situations where pregnant women have needed ICU care. And most importantly, a majority of our patients have delivered well. We haven't seen any significant large-scale maternal fetal transmission or even lactation, which has been shown to be quite permitted in these patients. So our role as the obstetrician was to start preconceptionally. I had patients asking me, should we have a pregnancy? Patients coming for a termination, and with reassurance, at least obstetrics pretty much seems to be back to normal. What about experiences of delivering or giving birth during the COVID cloud? Now, there was a study called the CARE study. And this study was done on social media platforms, emails to birth workers. And this was interesting. Firstly, denial. 1/5 of respondents were not comfortable speaking about their worries. The second was, and this was interesting, the provider had not gone that extra mile to discuss the effect of COVID on labor and birth experiences. 40% of all and 25% in the third trimester. About half said that something in their birth plans had changed, and we will discuss that later. And what does this tell you? This tells you that at this time, for the next many months or 1 or 2 years, you have to proactively voice what the patient wants to hear and might not be asking you. You have to preempt and tell a patient that I can understand your concerns. We are there for you. This is what COVID-19 does. This is what we will do to make it safer for you. And this is your responsibility as far as your life and livelihood is concerned to keep yourself safe. Near-term approach, when we come to the final preparation of childbirth, there are certain changes that could be made. I can tell you what I do in my practice. Firstly, we continued to see patients throughout the pandemic. We never stopped. But we did reduce the frequency of antenatal visits and basically seeing patients generally once a month, except for the very last month. And I'll tell you why we see patients more frequently then. We address whatever we can, and we always try to do this by remote access, by emails. We do our scans. Don't compromise on your basic investigations, but try and do something whereby she can do more than one thing when she steps out of a bubble or zone of comfort. And I cannot stress enough the importance of periodic in-person checkups, in which, of course, you have to protect yourself, your staff, and your patients. So appointments have to be staggered and kept to. Walk-ins should be discouraged. There has to be a protocol of clearing, cleaning, and sanitizing chairs, tables, beds with the patients. And something as simple as telling my patients that please come with your own bed sheets, because a clinic can't possibly have 2 or 3 dozen bed sheets. And basically what is done is, at that point in time, you may find yourself reusing, and that's something you just can't do. So small tweaks in your practice can make things possible. After 36 weeks early in the pandemic, when it was difficult to do our testing. You know how it was. We were asked to restrict. We used to do a weekly assessment, a Bishop's score, and then do that very precious limited test before planning a delivery, because hospitals insisted on PCR testing before going in. That has changed now. Testing is very easy. Hospitals still insist on a test. So patients are now encouraged that once we consider that they are close to delivery, they do a weekly COVID test, that so that at any given point in time, they would have a valid COVID PCR before going into hospital. Now let's talk a little bit about testing. Who gets tested? There has been so much confusion over the last so many months as to who tests, who doesn't test. Well, of course, people, cluster areas, containment areas, be liberal with your testing. I've always believed that when there is a choice between commission and omission, commit. If there is a choice, please do the test. Testing should be carried out in a center where the woman is admitted for delivery. We facilitate collection with dependable labs. And of course, there is a very important aspect of patient safety and repeat testing if there is going to be a delay. The gold standard is still the RT-PCR. That's the recommended standard. I know we have rapid testing now. We have also been doing some antibody studies, and we are surprised to find patients who are antibody positive who've never even known they had COVID. So for some time, we started testing all our patients at their 28-week tests and doing a COVID antibody test. And you'll be surprised to find from time to time a patient with almost no symptoms coming to be antibody positive. Of course, this is more a population level prevalence issue. As far as you are concerned, in spite of the 10 to 30% false negative tests, even with 2 swabs, it is important that the TB-PCR test, the RT-PCR test, remain your gold standard. Now, this is a very simple triage of a parturient in labor and delivery. What do? Firstly, make sure she has a valid test. There is a drive-through center in Mumbai, actually more than one drive-through centers which patients are very comfortable doing. If there is any doubt at the first sign of anything happening, I ask them for a valid test. But suppose they come to the hospital with an acute obstetric concern, diminished fetal movements or bleeding, do not hesitate to admit this particular patient. There has to be appropriate protection for providers, patients, and there has to be COVID testing. When there is no acute obstetric issue, you could offer telehealth approach and tell patients to stay at home. And a large number of my patients, almost 20 out of the 34, had COVID tests positive, had symptoms. We remote managed them at home. We advised them as to what to do. And then, of course, when they became negative and we were sure everything was safe, they came back to the clinic. Now, the decision making is time sensitive. For symptomatic patients with no urgent obstetric issues, you should ask them to stay at home and self-isolate. I mean, there are recommendations and we'll talk about some of these later, but basically for these women, self-isolate, take care of themselves, hydrate themselves well, monitor their parameters, monitor oxygen levels, monitor their temperatures, and most of them come out of it without difficulty. But if there is an urgent obstetric issue, then the hospital should be ready to admit these patients, and the hospital has to have a plan of how to look after these patients. Individual and partner screening is by local conditions. The general labor and delivery protocols don't change much, but now it is a recommendation that every patient should wear a surgical mask and every provider should have a surgical mask, because most of us have now completely shifted to the N95s and better masks. And there is a recent recommendation saying that double masking might make things safer. I think the only practical thing about double masking for the provider is we give more life and less contamination of our N95, which can then be reused more than once. One thing most institutions have done is don't take away the support, but limit the support to one visitor, to one support person. Preference is for support through video, which is great today. I have a setup in one of my hospitals where the husbands aren't allowed into the labor room or into the theater anymore, and the anesthetist usually has the husband on a video, and the husband is talking to his wife and seeing what's happening as the whole process goes on. All support people should be screened, and of course hospitals these days do not permit switching off visitors to minimize exposure for the hospital and visitors to patients. There should be obviously a designated support person who has to be identified. Now, there has to be a level 3 protection for aerosol generating procedures. All of us are quite familiar with this particular preparation and a PPE, but basically what do you need? Second stage of labor is an aerosol generating procedure. Disposable surgical mask, protective mask, a work uniform, a full PPE, and here we are talking about a patient who is positive or who is suspect. Disposable latex gloves and a full face shield. There are certain controversies with obstetric medications that we normally use. One medication that we've used is indomethacin. Indomethacin is used by us in patients with polyhydramnios. There is evidence to show that NSAIDs might worsen the course because the virus binds to the cells through the ACE2 receptors, and NSAIDs increase their expression. Use with caution. Tocolysis, consider nifedipine as an alternative to what we normally use, and that's the beta mimetics. Betamethasone and dexamethasone, there is a concern about systemic corticosteroids in viral pneumonia. There was in MERS at least a report of delayed viral clearance, but here let me say this: if the patient needs it for protection and for pulmonary maturation, judicious use is definitely recommended. What about thromboprophylaxis? Now, firstly, self-isolating women, ask them to be mobile, ask them to be well hydrated. This is a concern. If the woman is already taking low-dose aspirin or is she on LMWH, she continues, she does not stop. And there is a recommendation that all pregnant women admitted with confirmed or suspected COVID-19 infections should receive prophylactic LMWH, generally in a dose of 40 milligrams, unless the birth is expected within 12 hours. In one of our hospitals, Holy Family Hospital, we've set up a separate labor room for these patients, not in the labor room suite itself. It's nearby rooms have to be designated, that floor has to be designated. You do not require a negative pressure room. You just require an adequate, well-ventilated room, which should be then sanitized between cases. Induction of labor at 39 weeks in asymptomatic patients with counseling. Early in the pandemic, we did inductions because we were bound to do a single COVID test and then deliver her within the next 7 days. The option of beginning induction process at home has been described, particularly in the West. I must tell you here that I do use mifepristone, 200 milligrams. In a case, we have a very poor Bishop score, 48 hours before the induction, and the induction becomes extremely successful. This is supported by a Cochrane review. A combination of a Foley's catheter, less used by us but extremely popular down south and in the West, or PGE2 over 12 hours, followed by 25 micrograms of misoprostol every 22 to 4 hours, usually does the trick. The cesareans does not have to be performed before 15 hours of oxytocin, and an amniotomy if feasible. And just because she's COVID positive, you do not need to do a C-section. First stage of labor, oral administration of water clear fluids like we always do. When there is oral restriction, dextrose IV, oxytocin augmentation to shorten the time to delivery when there is a slow progress, with the use of a partogram, and make sure that you step in to prevent and treat dysfunctional labors early. And a C-section is done when there is an arrest of the first stage, only if the arrest is for more than 4 hours, if everything is adequate, or 6 hours when activity is inadequate. So don't be in a rush to do a C-section. Vaginal delivery is probably safer for her and for us. What about analgesia or anesthesia? Early epidural has been recommended. Neuraxial anesthesia is not contraindicated. In fact, the use of Entonox is discouraged because anything to do with the airway can increase the risk to the anesthetist, and even oxygen via nasal catheter, though not considered an aerosol, my recommendation is don't do anything which is not absolutely required. Keep the patient's face and mouth covered with a mask, and that would definitely be safer for the staff. Second stage of labor, it does not need to be altered from the routine. They do not delay pushing because delay increases time to delivery, chorioamnionitis and PPH. An assisted second stage could be necessary, go ahead, and doing a perineal massage and warm packs usually has fewer lacerations. And as I've often said, I don't do routine episiotomies, and my patients all deliver with first and degree, second degree P tears, which really heal well. If it's a COVID-19 suspect patient or a positive patient, N95 mask, full droplet protection for providers, and please minimize the staffing and don't go on changing providers. We've got speakers who will speak on the intensive care management, but the aim is to keep saturation above 94%. Monitor the fetal heart continuously, but remember, once you expose your machines to a COVID positive patients, they have to be kept aside and sanitized well before they go back into your general obstetric unit. No evidence to favor one mode of delivery over the other, so do whatever is obstetrically justified. Epidural analgesia definitely recommended if required, and individualized decision taking, but elective instrumental delivery might definitely benefit. Now, this is just to show you the kind of what you require. I've just boxed two places. This is a COVID suspected or a positive patient. Obstetrician, double or triple glove to ensure no contamination. Post-operatively, appropriate removal of all PPE. This is the danger step. My friends who work with a lot of COVID patients and friends who've turned COVID positive say this is when they are at the maximum risk. So this is a video that was done for MOGS some time ago, and I keep seeing it from time to time to remind myself what I'm supposed to do when I'm doffing my PPE. You are safe as long as you are in your PPE, but if you don't take your PPE off well, wear an extra pair of gloves, sanitize at every step, do not allow contact of your skin with the possible contaminated tissue materials, the PPE. Again, keep sanitizing. Very carefully get your PPE off. And this is something that has to now become a part of our lives. This is not something we've given a lot of thought to, because this is what for us is the difference between an infection and protection and our well-being and our patients' well-being. So I think we should have these things on the wall. We should have these videos being seen regularly. And this is what is going to help us do things right when we look after these patients. Finally, the third stage of labor, there is a concern about limited resources of blood. So please actively manage the third stage of labor. Besides standard oxytocin, use prophylactic tranexamic acid, use buccal misoprostol, consider cell salvage at C-section if that facility is available. And of course, if transfusion is indicated, start off with 1 PRBC at a time. Neonatal consequences. Now, this has been shown that there is no increased risk of miscarriage or growth restriction. The median gestational age in the UK was 38 weeks. Preterm births were more likely to be there because 47% were iatrogenic, and neonatal infection in third trimester infections was just 5.6%. Neonatal care, there has been some controversy, but today it's accepted that while you need to protect the baby from droplets, while the mother needs to gown up, lactation should not be denied to a patient in a COVID positive mother. Vaginal deliveries, you could try and expedite the discharge if all is well. C-sections could also be expedited, less pressure on the system. Postpartum visits and wound checks could be done remotely. These days, I call the postpartum patient once after maybe about 10 to 15 days and try and delay the follow up so they have to have less coming out of their safety zone. And finally, contraceptive choices. We have to think of new ways of practice. We have to think about telemedicine. You can prescribe things like progesterone only contraceptives, and these can be gotten from online pharmacies. This is the time to promote the postpartum IUD. We fail to have these picked up in private practice. I think this is the time, if an activist, if the advocate wants to push it, keep the patient safe, give her a postpartum IUD. She doesn't need to do that one additional follow up. And if a ligation is required, please do not deny her the ligation. What about vaccination? Now, this is going to be a controversy. Presently, there are two different points of view, but FIGO has recently come with an opinion. We'll have to wait to see what evidence catches up, which supports offering vaccines to pregnant and breastfeeding women, because they say that the risk-based approach has to be kept to the benefits of universal protection and immunization. What we can do is, these are our resources. There is the FOXY resource, which is one of the best things we've created. There is the RCOG resource, which I read often. The next resource is from the Society of Maternal Fetal Medicine and the ICMR guidance. Please download this on your phone, on your devices, and keep referring to them from time to time. I'd like to end by quoting two people I admire greatly. Atul Gawande, who said, "The new normal is to learn from each other and learn at hyper speed." And Sanjeev Puri of the ITC, who has said, "The longer we take to adjust to the new normal, the more stressful we make the situation in the long run." I suppose even this technology of webinars, even this platform of the webinars is our adjustment to the new normal and is one move to learn from each other at hyper speed. For this, I must say thank you to Niranjan and Komal and the supporters who made this possible. Thank you very much.
Thank you so much, Dr. Nozar, sir, for that lucid presentation. And you have covered from the beginning of inception of pregnancy to delivery, to going through all the trimesters, post-delivery, lactation, and also contraception. I think I did the right job of getting on board, and it being a Saturday evening, I appreciate that we have got more than 500 viewers live logged in to see you and to hear all of us, the experts, to be there. So thank you so much, sir.
Thank you.
I hope, I think in Mumbai, you were the first obstetrician to get vaccinated on the 16th when it was launched in Mumbai. And there was Dr. Bhaskar Pal who also got vaccinated at the same time in Kolkata. Of course, there were many other obstetricians working in the government and municipal hospital who also got vaccinated. And I'm sure now most of us obstetricians have got the second dose, presumably by the 16th of March. Most of us healthcare workers also in Mumbai would have undergone the same thing. Now, sir, there are patients which are, I have got some two calls. One was on the helpline, that is 1075. This lady was has taken first vaccine and then she did her UPT, and she is a pathologist. I can't divulge the details, but she is about 5.5 weeks of pregnancy. So the question asked was whether she should now withhold the second dose of the vaccine, and the most important, that does she have to terminate the pregnancy or continue? So what is your opinion regarding the same?
So I think we'll probably have to wait for a clear-cut recommendation from W. But let's go by whatever the recommendations we have now. The recommendation as of now is not clear on vaccinating someone in pregnancy. So as far as that is concerned, I would wait and watch, and maybe she should hold the second dose. It would be very unfair of us to make a recommendation based upon common sense and not upon science. As far as terminating a pregnancy is concerned, no, I don't think there is absolutely any need for that. And the reason why I say that is, having now had a number of patients who've not just, who actually had COVID infection in the first trimester. And I think there has been no significant increase in harm in terms of miscarriage. And we've now got a number of studies saying this. We do not have any reported increase in abnormalities. I think she can definitely go ahead with the pregnancy. Whether she should take the vaccine later, the second dose later, I don't know. Maybe she should wait. Anyway, the recommendations that are coming now is to delay the second dose. Whereas we may have a recommendation and they say the best results come in 12 weeks. So I would probably tell her, you know what, even if you waited, you wouldn't do any harm. In the next 1.5 months, if a clear recommendation comes from the WHO, which it might, they are looking at this very closely, then she can still take the second dose and not lose the benefit of the first. But by which time she should probably have gone through the first trimester and she would be in the early second trimester. So wait and watch, no termination, but at this point in time, the judicious thing would be to hold the second dose.
Sir, you are also aware that apart from the COVID vaccine which is available, we have hepatitis vaccine, we have DPT vaccine, we have also H1N1 vaccines, and I think most of them have the trials have been conducted also on the pregnant woman. And as you have said, there are still data to come. Furthermore, there are one or two vaccines. One, I think, which has been also tried on pregnant women. So until and unless that result comes to a certain extent, it will be advisable, number one, to, as you have suggested, to continue the pregnancy. Number two, to delay her second shot of the vaccine. But in spite of, sir, our best efforts, and in spite of how much ever we counsel, there is always a benefit of doubt, or there is something hovering in the mind of the patient that if this vaccine which he has taken, will it cause any congenital anomalies or probably any defect to the baby, or it might affect the mutation of her genes. So what is your take on this?
So firstly, one big concern that has come up with this pandemic is that there are certain things we took for granted in science, and we've suddenly started compromising those, and we've started taking shortcuts. And that's made most of people with a background in science very concerned. You know what concerns we have about phase 3 trials and the like. That's what's probably led to a lot of concern and suspicion. Finally, the patient has the last call. And it's not just, why are we just talking about COVID? We've got patients with significantly abnormal glycosylated hemoglobin. You've got a patient whose TSH might be 16. You've got patients where you would have concerns about outcomes. And at the end of it, when you have this discussion with your patient and you make whatever recommendation you want, it is the patient's decision as to what she wants to do with the pregnancy. If this patient decides to continue, support her completely, close vigilance, I'm sure everything's going to be fine. But you cannot guarantee that or assure that. If the patient decides to terminate, it's not for you to try and talk her out of it. Go and terminate it. Full support, make it possible, and let her come back after the second dose when she is ready after 6 weeks or 2 months or whatever. So for me, I believe, like any obstetrician, what the patient wants matters more than anything. I've always told my patients, if you want it, I want it.
Sir, there is one more query I have received. It is also about a healthcare worker, an obstetrician based in South India. She is 36 years old and her husband is a 38-year-old. He is also a professor in one of the medical colleges, and she is anxious to conceive. She wants to conceive. So, what is your recommendation for such patients who are having infertility, or should they defer the pregnancy for the time being till the COVID pandemic, because she is already vaccinated once? Now, her question is whether she should conceive in this period, and if she conceives, what will be the future of the child?
So I don't think the pandemic really has made that kind of a difference to whether a patient wants to conceive or not. I'll give you a very interesting experience, and many colleagues have experienced that. March and April was panic. People were afraid. Some people came and asked for terminations, though interestingly, they couldn't even come to us because most doctors had stopped practicing. So they often came end of first trimester. By May and June, things people were suddenly wondering, and a lot of people had this opinion saying, you know what, I'm not doing anything anyway, might as well plan my pregnancy. And if they're at a favorable obstetrician, well, they plan their pregnancies. My list of patients due in May, June, and July this year has absolutely gone through the roof. I think because of that. I don't think anyone needs to wait because the pandemic is on. There'll always be something like this happening somewhere in the world. I think people need to be sensible and responsible. If the cricket teams can play cricket safely in these pandemic times, why can't a pregnant woman have a pregnancy safely in these pandemic times? If they can live in a bubble and be safe, what's so difficult about being careful, controlling your environment, masking up, maintaining safe distances, sanitizing your hands and washing your hands? And if there's one thing that the pandemic has done, it's shown me that if people just wash their hands frequently and wear gowns and sanitize, there'll be less common colds, less influenza, less diarrheas. And that's what I saw in my practice over the past many months. So I think this should not make a difference. I know that our infertility colleagues stopped practicing for the first many months, but patients who asked me whether she should go ahead, well, my thing to them was, well, if you want to, you can. If you don't want to, don't. We are there to support you any which way. And we've delivered so many patients now. And I believe COVID has been kind to pregnant women and kind. I'm not saying it can't do harm, but generally it's been kind to pregnant women. It's been kind to babies. And by association, it has been very kind to obstetricians.
Sir, last question from my side before I hand over the mic to Dr. Komal Chavan. Sir, have you seen in those 34 cases something related to IUGR or a preterm birth, or it was a weak cry of the baby, or any difficulty, or the gross appearance of the placenta? Because there are many studies which have come out from all over the globe that those patients with PIH and anemia, their placenta is similar to that of a COVID patient, or they have some amount of IUGR. But some studies also have said that actually they don't have IUGR, they have normal babies. So what is your take on that, sir, with your experience?
So 34 is a small cohort, and I have definitely not seen that. But I must also tell you what I did. I saw my antenatal patients from the very first day of the pandemic, less often, very carefully, but saw them. And I did see a number of reports, and a few patients came to me with problems. And I believe that their problems were not because of the disease, but were because their provider was not seeing them personally. Patients were managed remotely. You cannot manage an antenatal patient remotely. I've had patients of mine who've come with IUGR, but I believe that probably happened because they had not seen an obstetrician in 2 or 3 months. And by the time they came, this would have been possibly something that would have been picked up earlier, preterm deliveries. So I personally believe, don't lose your balance, don't lose your science, be judicious. Your patients, if you've looked after them during the pandemic, will be your biggest fans and the most grateful patients in the world. I mean, when this happened, patients were so emotional that they were being seen when a lot of people had completely stopped practice. Having said that, don't ever be careless. You owe it to your families, you owe it to your staff, you owe it to your patients. Even today in our clinic, when patients come in, each and every one of us, doctors, receptionists, staff, is in a washable PPE. Everyone's wearing an N95. We wear shields. We sanitize. Every surface is sanitized. Don't get tired. Don't get fatigued. Continue to do this month after month after month for as long as is necessary. No patient is allowed to come in with more than one person with them. We do not allow the partner in the examination room anymore because usually that's a small space. And keep talking to them and reassuring them. Give them remote access. I think we can do it and we can see this pandemic through. And let's not forget all these lessons for the future. Let's make this practice better for ourselves.
Wonderful. Wonderful pearls of wisdom. So you have done a great job by explaining the details. I hand over the mic now to Dr. Komal Chavan, my co-host.
Thank you so much, Nozers, sir. It was a real excellent presentation and so practical. You highlighted what we should do at every step, right from the time when a patient comes to you till the labor. You have guided all the practicing obstetricians so well that what the obstetrician needs to do for themselves as well as to the for the benefit of the patient. So that was a real enlightening talk, and those were your golden words. I'm going to keep in mind every time. I have taken down all the points and so well said. Sir, I just wanted to ask that out of the patients you manage so many patients, like as a private obstetrician and gynecologist in city of Mumbai. What about their acceptance about breastfeeding? Were these mothers were practiced breastfeeding post delivery, or there was an alternative feeding given to them?
So, thank you, Komal, for bringing out that point. A lot of it depended upon the pediatrician and the approach of the pediatrician. Initially, when we started in one of our hospitals, the babies were kept apart. A family member looked after the babies. The mother was pumping and passing on the milk, and that was given to the baby, and that's how it worked. In another hospital, we were allowing rooming in. Nothing seemed to have gone wrong. Everything worked well. I think that was early in the pandemic. We've now come around, and if the mother is otherwise healthy and otherwise asymptomatic, if she can be taught how to be safe and prepare, feed by sanitizing, gloving up, wearing a mask, there does not seem to be any contraindication to lactation. But here again, this is me. I will allow the mother to make this decision. I will allow the mother to decide. I don't think it's for the neonatologist, pediatrician, or the obstetrician to judge her. Remember, she is a woman. She has got concerns. She has got her own psychology. If she believes that for the baby's safety, she is making the decision to be apart and have the baby fed by formula for some time, so be it. So be it. If this mother is going to be a nervous wreck, wondering every day for the next 2 or 3 weeks, is my baby going to be positive for COVID? Am I going to be responsible for infecting my baby? Please respect her.
Yes.
Because otherwise you are definitely going to land up with a case of not just postpartum blues, but postpartum depression and all its consequences. But I would defer to my pediatric colleagues, but there is very clear guidance now from all authorities, the WHO, that you can breastfeed. Breast milk is safe. And if you can keep a certain amount of protection and barriers, there is no reason for the woman to deny her baby lactation.
Yes, very well said, sir. Actually, you have taken yourself into the mother's perspective, because definitely, as we know, the guidelines are saying that breastfeeding is safe and it should be recommended. But there is a lot of hesitance on part of our patients only from themselves. So at that point, what we should respect, that is very important and very nicely said by you. Thank you so much, sir.
Thank you. Thank you.
Thank you so much, sir, for your valuable time. And I know, sir, you have been very busy uh, on behalf of Science Integra, TOG, and MCure Pharmaceuticals Limited, and of course, Foxy Medical Disorders in Pregnancy Committee. As a national coordinator, we would like to thank for you being here today. Thank you so much, sir, for being with us.
Thank you. Thank you all.
Now I welcome our next speaker, Dr. Taslima. Doc- uh, Dr. Taslima is the assistant professor at Lokmanya Tilak Municipal Medical College, popularly known as Sion Hospital. She is an MD. She is faculty in the neonatology department, having done the fellowship in neonatology, and lactation consultant, a trained lactation consultant. She has an experience of more than 500 babies being managed at Sion Hospital during the COVID pandemic, which is still going on. And what most significant thing she has done, she's going to reiterate and inform and tell all of us how her journey was and what best she has done. And she's representing Dr. Jayashree Monkar, who is the head of the department, and Dr. Swati Manerkar, who is an associate professor in our department of neonatology. I would also like to reiterate and tell all of you colleagues that Sion Hospital is the first in India to start the milk bank, and it has now also guided other states and other cities to have this milk bank. And the latest milk bank which was founded was at Kochi, that is the Amrita Medical Center, and Dr. Tessie Lewis is also one of them who has taken all the inputs. So I hand over with this brief description and welcome Dr. Taslima. You have done a wonderful job of delivering so many, managing so many neonatal babies. And I hand over the mic to you. So please go ahead with your presentation on neonatal management in COVID-19 positive mothers. Thank you so much for being with us.
Good evening, everyone. Thank you, Niranjan sir, Komal ma'am, and all the organizers of this Foxy webinar. I would also like to thank my head of the department, Dr. Swati ma'am, Dr. J ma'am, for giving me the opportunity to talk today on the neonatal management in COVID positive mothers. Um, we will be seeing today about the problem statement about what is COVID-19, how does it present in the neonates, how do we test them, how do we manage, and a few slides on our experience during managing the neonates in the COVID pandemic. COVID-19 does not need any introduction. Since December of 2019, the world has been gripped by this COVID-19 pandemic, affecting almost 1,100 million cases worldwide, with almost 2.5 million deaths been recorded. India alone has almost 11 million cases till now, with almost active cases of 16,000 cases rising even today. About the pregnant women, we do not have so much of a data or a real-time data which would state like how many pregnant women have been affected. But in the US, the CDC has said that till now there have been 71 plus cases of COVID-19 in the pregnant women, and there has been 11,000 plus cases who have completed pregnancies, and almost 60 neonates have been tested positive in the US alone. In Mumbai, if there have been three published data from three public hospitals in Mumbai, which have reported almost 57 neonates to be tested positive by an RT-PCR for COVID-19. So, for neonates to acquire this infection can happen either during the entire pregnancy, during delivery, or postnatally. The vertical transmission can take place from the placenta, or by the blood, or by the amniotic fluid. Till now, there have been very rare cases which have reported an intrauterine transmission, and it still needs to be investigated to say that intrauterine transmission may take place. For all the swabs which have been done from the vaginal secretions or through the cesarean delivery, the amniotic fluid, it does not has never been tested to be positive. So the transmission during delivery to occur is also very unlikely. Even breast milk does not transmit this infection. So most of the neonates, they acquire the infection through horizontal transmission from an exposed or an infected mother or a caregiver through respiratory droplets and contact. Most of the neonates till now, when we characterize the neonates born to this SARS-CoV-2 infection, they have been found that they remain to be mostly asymptomatic, or they may have mild clinical abnormalities. If they are symptomatic, then they can present with respiratory symptoms or respiratory distress. They can have fever, poor feeding, lethargy, even seizures. There have been only 6 to 10% of the neonates which have there are only 6 to 10% of the neonates which have shown to be positive. Almost 46% neonates have been admitted to the NICU, and 82% of the neonates have been discharged according to this study. When we talk about COVID-19 and how does it affect the pregnant women, There has been a co-reporting of the common outcomes from the UK and the US registries, that is the pregnancy and neonatal outcomes in COVID-19, that is the pan-COVID study, and the American Academy of Pediatrics section on the neonatal perinatal medicine registries. And they have seen in among 4,500 pregnant women who were suspected or confirmed with SARS-CoV-2 infection, that in them the preterm rates of delivery were higher, and these preterm deliveries occurred around 32 to 36 weeks of gestation. There has been no there has been no conditions in which they have found there has been no clinically significant effect on the fetal growth or adverse neonatal outcome or the rate of stillbirth. What can be concluded from this study was that every pregnant woman needs to be counseled that SARS-CoV-2 infection will increase the risk of preterm delivery, but not that of stillbirth or of early neonatal death or a small baby being born. This also makes us realize that antenatal corticosteroids needs to be administered to all the preterm pregnant women who are likely to deliver within the next 7 days. And also for fetal neuroprotection, magnesium sulfate has to be used. Even the practice of delayed cord clamping, irrespective of the COVID-19 status, has to be followed. So how do we test these babies? We use the nasopharyngeal swab or the tracheal swabs if the baby is intubated. The testing has to be done. The confirmatory or the diagnostic testing is your RT-PCR. If we require, in case of emergencies, if we want a turnover time that the reports be available in a few hours, then a TrueNAT or a CBNAT can be done. If we want a point of care testing, then a rapid antigen testing can be done. When should the neonates be tested? There are three indications for it. If we strongly suspect a perinatal transmission, that is, if we find that the mother has having COVID-19 infection was detected within 14 days before the delivery or within 2 days after the delivery, then there is a high risk of perinatal transmission. And so these babies need to be tested immediately at birth or within at least 12 hours. If your first test comes negative, then the repeat test has to be done around 5 to 10 days if the babies are symptomatic. But if it is symptomatic, then an earlier testing will be recommended. If there is a history of exposure to a COVID-19 positive person, that could be the mother or the healthcare provider or any family member, then these neonates will have to be, if asymptomatic, then they test them at day 5 to day 10. If symptomatic, then you need to test them immediately. If you find that the neonate is symptomatic, that is having severe acute respiratory infections, or they have sepsis-like illness, that is respiratory distress, lethargy, seizures, apnea, refusal to feed, diarrhea, then we have to test them at the first time when it is evaluated. If this test is negative and there is still a high risk of suspicion, then repeat the test within 24 to 48 hours. If you find that the first test has come positive, then the repeat test will be done only according to the severity of the illness prior to the discharge. During the COVID pandemic, the FOXI, the NNF, and the Indian Academy of Pediatrics during the first quarter of last year recommended a lot of had a lot of recommendations of how to manage babies who are born to SARS-CoV-2 positive, suspected or confirmed mothers. So in the labor room, when we have to prepare for these births, it is recommended that the neonatal team should comprise of minimum personnel. That is, at least one neonatologist will attend the delivery if it is a low risk case. If it is a high risk, then at least two. And this has to be done in a full set of PPE and wearing an N95 mask. Even the mother has to perform a hand hygiene and wear a triple layer mask. If the baby is going to require resuscitation, then it is earmarked that a physically separate adjacent room should be available. If not, then a warmer should be placed at least 2 meters away from the delivery room area. If that is also not been possible, at least a curtain that is going to separate the two areas so that minimum contact or exposure to the staff can take place. For a neonatal resuscitation will be done following the standard NRP guidelines. There is nothing different that we are doing, only aerosol generating procedures, they have to be minimized. If we are using a positive pressure, if the baby requires a positive pressure ventilation and we are using a self-inflating bag and mask, then that has to be disinfected before use. If you are using a TP's resuscitator, then it is advised that the tubings that have been used has to be disposable. If the baby requires an intubation, they will be indicated irrespective of the COVID-19 status. The only thing that we need to avoid is an endotracheal administration of the medications. Even a suctioning will be avoided. Bathing is normally avoided because of the risk of hypothermia and of hospital-acquired infections. But we need to practice a delayed cord clamping and even skin-to-skin contact when we have a labor room management. If we find that the baby is sick or it is symptomatic and it is born to a suspect or a confirmed SARS-CoV-2 infected mother, these babies need to be managed in a separate isolation facility. These separate isolation facilities should preferably be a single closed room. It should be separate from your normal routine NICUs or your SNCUs. If these facilities are not available, then use a closed incubators to manage these babies. Even if that is not available, then a radiant warmer. And the distance between these radiant warmers should be at least 1 meter apart from each other. These areas have to have a negative pressure area so that we do not generate any aerosols. If it is an air conditioned room, then remember that the air changes should take place almost 12 changes per hour, or else use an exhaust air fan. Your team should be separate for both your regular NICUs and for your separate isolated areas for your COVID babies. How do we treat these babies? If they are symptomatic, requiring a respiratory support, all the lung protective strategies needs to be followed. If most preferably do not intubate, use a non-invasive ventilation like a continuous positive airway pressure. Avoid using an intermittent positive pressure or high flow nasal cannulas. If the baby requires intubation, use it for your usual indicators. Only try to avoid suctioning. If permitted, then inline suction device or HEPA filters can be used. How do you treat them? For all these babies who are symptomatic COVID-19 neonates, they do not have a separate treatment plan. They are treated according to your routine and NICU protocols for their neonatal morbidities. There is no antiviral drugs specific for COVID-19 being recommended, nor are any systemic corticosteroids or intravenous immunoglobulins or convalescent plasma therapy recommended for the neonates. When all the studies till now that we have found is that most of the neonates born, they remain stable or they are asymptomatic or they do not test positive despite the fact your mother is COVID-19 positive. So for these babies, it is imperative that we continue to room them in with their mothers. These mothers have to be encouraged to exclusively breastfeed their babies. We need to keep on re-emphasizing the fact that the mothers have to do this following all your hand and your respiratory hygiene. If the mother is sick or if your neonate is sick and the rooming is not possible, then how do you feed them? We can feed them by mothers expressing their milk and then providing it to the babies either by the nurses on duty or their family members who can actually take care of these babies. For every baby who is stable, your essential newborn care is always provided along with your lactation management. All these babies need to be immunized, that is given their birth doses of your BCG vaccine, your oral polio vaccine and your hepatitis B vaccine before discharge. They need to be discharged earlier, and if follow-up is required, a telephonic follow-up can be done or a home visit can be done. That was during early months of the pandemic, but now they are advised to come back to our outpatient department for a regular follow-up. If the mother was infected with COVID-19, how do these mothers visit their babies in the NICU? They are allowed only when the fever has been resolved without the use of antibiotics for at least 3 days. There have been improvement in their respiratory symptoms and their COVID swabs have tested negative. Only then they have been allowed in the NICU to visit their babies. If you have to talk about discharging a stable neonate, uh, who has been tested COVID-19, who have been we have been able to room in with their mothers, then they can be discharged with the mother when both of them are being stable. Suppose if we have a COVID negative baby mother and a baby, sorry, a COVID negative mother baby, and they have been stable, in whom rooming in was not possible, then they are discharged around 24 to 48 hours of age if they are stable. And if you have an asymptomatic COVID-19 positive neonate or those with mild to moderate clinical course whose symptoms and need for oxygen has abated within 3 days, they can be discharged. Uh, it is very imperative that now we focus upon what has happened during the early months of the pandemic. A lot of confusion was there, a lot of doubt was there whether the babies have to be roomed in, whether they should be given breastfeeding or not. So, in this COVID mother study, which has been published recently in the breastfeeding medicine, from the 31 countries, they have found that those mother and the baby who were not directly breastfed, those who experienced did not experience a skin to skin care or who were not roomed in, there was a significantly less likelihood that they would be able to exclusive breastfeed in the first 3 months. In those mothers, almost 60% of these mothers had experienced separation from their babies. They felt very distressed, or they were stressed out, and 29% of these mothers were not able to breastfeed. So, what we need to remember from this study is that your evidence based maternity care practices of breastfeeding, of skin to skin contact, should never be disrupted, because if it does happen, then it is going to be create a lot of harm, and it is actually unnecessary. Something which has been supported even by the WHO. This is a public policy which the WHO has just published in the Lancet about the feeding policies and the mother infant contact. There has been a lot of evidences which has shown that SARS-CoV-2 transmission in the mother and the infant contact and the breastfeeding. There has been intermittent reports which have shown that SARS-CoV-2 RNA virus is identified in the breast milk. But in spite of the fact that it is identified, there is no reports which have said that transmission has taken place. Rather, breast milk has been found beneficial because the antibodies against SARS-CoV-2 has been identified in it. Along with that, breast milk already has anti-infectious molecules like all those peptides, the proteins of lactoferrin lysozymes, which already has potential anti-SARS-CoV-2 activity. So the WHO has concluded saying that we need to support the mother-infant close contact. We need to support these mothers to breastfeed by encouraging them to practice hand washing and wearing a face mask. Also, all those people who create, exploit, or seed a doubt about breastfeeding for commercial interest, there should be a public health authorities which should address these problems as much as possible. A few slides on our experience during this COVID-19 pandemic. What we found during the early months was that our hospital was divided into two sections. One was a dedicated COVID hospital, and the other one was a non-COVID hospital. Dedicated COVID hospitals were those in which all the pregnant women who were tested to have COVID positive status were delivered. Their sick neonates were admitted to the NICU. If you had an outborn baby who had a positive report, then they were also managed in this dedicated COVID hospital. Ours was a non-COVID hospital wherein routine care was also provided. Along with that, we were also managing your COVID positive babies. So all the pregnant women who had a COVID negative status, or who were suspected to have a COVID symptom, or those who were tested during labor after the admission, were delivered in these hospitals. Their sick neonates were admitted in the non-COVID in the NICUs, and all those outborn babies who required admission but did not have any confirmatory swab reports, they were also managed in these NICUs. In our non-COVID hospital, we had dedicated sections of COVID areas, of holding areas, of your non-COVID sections. So your COVID areas included all those mothers who had positive, who had swabbed positive. So we had a area which was earmarked for your labor room, your resuscitation area, your postnatal care area, NICUs, your step down areas, they all had to be separate. Similarly, for those mothers whose reports were still awaited, a holding section was created, and a non-COVID section areas for those who were COVID negative. But all of this created a lot of shortage of spaces, manpower difficulties, finances problems, but we did deal with them as and when it was required. When we had to triage in the holding areas, the triage, how did we do it? So if we had a mother who had tested SARS-CoV-2 positive, and these mothers, if the baby was stable, the mother and the baby were moved into the COVID PNC ward. They were bedded in, they are groomed in together. We encouraged them to breastfeed. All these mothers were counseled about how to maintain a respiratory hygiene, about how to do a hand hygiene also. Routine care was provided in these PNC wards. The babies, the babies were tested by nasopharyngeal swab and RT-PCR once the mother's COVID report was available. If they were negative, then they continued to be bedded in with the mothers, and they were discharged when both of them were stable. If the mother, if your neonate had tested SARS-CoV-2 positive but was symptomatic, then these neonates were shifted to a separate isolation area earmarked for your COVID babies, along with your pediatric and the neonatal patients. If you had babies who were positive but remained asymptomatic, then they were continued to be bedded in the PNC ward. We encouraged breastfeeding in them, and routine neonatal problems were addressed. Earlier strategy was that on day 5 of life, they had to be tested for a SARS-CoV-2. If they were negative, so we continued their routine care in the PNC ward, and an early discharge was planned. If it was positive, then we did a repeat testing around day 10 of life, and if they remained still positive, then we would discharge irrespective of their COVID report if they were asymptomatic. But these testing was later on revised as and when the recommendations had come out. What we had mainly focused upon was supporting the breastfeeding and having a family centered care. So all the parents, all the family relatives were actually counseled. They were given an update about the health condition of their neonates. They were given and the breastfeeding counselors would always go into the PNC wards with a PPE donned, and would tell them the benefits and the risk which is associated with breastfeeding, so that they had their own they took their own, mothers would take their own decision to breastfeed. So all these mothers have been encouraged to exclusively breastfeed irrespective of their COVID status. Those babies who were in the NICUs, the express breast milk was provided in small containers, which was expressed by the mothers and then transported with their family members. But the problem that we had during this time was a shortage of the donor human milk. So we had to prioritize which babies received. So very low birth weight babies were firstly given this milk. Also, because of the donor screening criteria, we had basically felt a shortage in the DHM. So COVID-19 positive mothers were not your donors for at this point of time. But there were reports which later on they showed that Holder method of pasteurization does destroy the SARS-CoV-2. So it is required that all the policies about how to donate has to be revised, looking into this matter. So this was our small study which we had the opportunity to publish in the Indian Pediatrics. We had found 17 units tested positive during our in this 1 year period. We found that all of these babies were term babies. They were all asymptomatic. All of them were tested after 24 hours of birth, and most likely they had acquired that infection by horizontal mode. All of these babies, being asymptomatic, being stable, were bedded in with the mothers. since birth if the mother was stable. We had exclusively breastfed these babies, able to immunize them on time. There were very non-specific complaints that the babies had, like jaundice and feeding problems, which are addressed accordingly. A few of the babies did have mild fever, but they were able to be managed properly. A few babies, we had seen that there was a raised LDH levels. Now these levels are likely indicate a critical stage, but fortunately all our babies were able to be managed properly and they were discharged along with the mother. When we had done a follow-up studies at 3 months of age, all of them remained to be asymptomatic. So what is my take home message is that COVID-19 pandemic is going to stay with us for a long time. So we live now in a very new normal world, wherein every day we find that the new studies evolve. There are new rates which have been coming out, but new things are something which we every day we are learning something new. So, but what remains is that for a good neonatal outcome, the breastfeeding practices have to be supported, they have to be promoted, and they have to be protected. Telling them that hand hygiene and respiratory hygiene is a must. Thank you.
Uh, Thank you so much, Dr. Taslima. What a wonderful presentation. And I am complimenting you. Your voice is just like a small, I can't say a neonate. Please
It's like
don't
a
take it the
training.
other way. Even Gunjan is smiling, but really, you're so impressive and nice. And it's a pleasure. We would also like to thank our Dean, Sir, Dr. Mohan Joshi, who has been very kind enough, and he always encourages me for such scientific programs. And today, neonatology and obstetric gynec department is working hand to hand. And of course, we would also like to thank our head of the department, Dr. Arun Naik, who is spearheading this whole COVID pandemic issue. And we have got a lot of support from other departments. And I find that you have also now published a paper in the Indian Pediatric Journal December 2020 where 17 babies have been found to be positive. Uh, and the follow-up which you have done. I want to ask you, Dr. Taslima, once they follow up in the OPD when they come back. So when do you test again? When do you do the test again? And you have advised breastfeeding for all of them, or some of them who are reluctant had to shift to artificial milk products, okay, or galactogogues or something, of that sort, powders. So, what is your take on that?
What we have experienced is all those babies who have had a follow up with us, they have remained to be asymptomatic. So, if you have asymptomatic babies, then we do not test them. It is not required that they need to be swabbed again because they are asymptomatic. There has been no exposure to them. Secondly, about breastfeeding, we have a very robust lactation support in our hospital. So all of these counselors have had a group counseling. They have had a one-to-one counseling with these mothers, wherein they have been encouraged that breastfeeding has to be continued. Those mothers who were not able to have a sufficient milk output, yes, galactogogues were given time to time, but we do not ever encourage these mothers to give formula feeds, so they have to be breastfed.
Yes. Um, uh, what is the future plan which you have said regarding the milk bank? How much important was it for COVID babies?
For all those COVID babies who have been admitted in the NICU, despite the fact that we were a non-COVID hospital, our admission rates continue to remain very high. That is almost 200 to 300 per month. Because the mothers were not able to donate, most of your milk which comes is through donation, either from the PNC wards or from the OPDs. So that had rather than a longitudinal donors, so that was a bit of a problem during the early days of the pandemic. So we had to revise our policies. So all those babies who were very low VLBW babies, they were the first ones to receive donor human milk bank milk. And at the same time, we were trying to encourage the other mothers so that they would keep on expressing their milk so that they can be, some or the other way given to their babies.
Thank you so much, Dr. Taslima, to be there with us and sharing the science experience. It was
Thank you, sir.
wonderful to have you to give also your valuable time. But before I end, I would like to hand over the mic to Dr. Komal Chaman to uh, add her few words or any questions she has in her mind.
Thank you, Dr. Taslima. It was a very nice from a
Thank you,
humanity
ma'am.
perspective, and you have actually managed so many COVID positive mothers, and then you shared your experience also. And how much we like the Sion Hospital is always doing a lot of work, and because of the workload, you have that vast experience, and you actually did justice to the topic. It was very nice, but I just wanted to ask something that in a have you seen any mother just being a high being just COVID positive or something that way? Like if
Sorry,
the
can you
mother
please?
was not positive and there was a neonate who was COVID positive or something that way.
No, till now, no. The 17 babies that we found to be positive, they were all delivered to a SARS-CoV-2 positive confirmed mothers. So we did not have all of those 17 positive babies were delivered to it. So it was most likely a horizontal transmission because these babies and the mothers were stable, so they were bedded in.
Because
So
that is
most
the
likely a horizontal transmission
yeah.
because none of, sorry.
Sorry, my connection I think is unstable. You continue.
Yes, so all of them were born to COVID positive mothers itself. So nothing of the mother not being negative and the baby being positive. Such a scenario we did not arise for us.
Yeah, so then surely the 17 positive mothers that shows that that was because mother to the child transmission. That is what you want to put it as.
Yes, very much likely that it has happened through a horizontal transmission. But we need to remember that how many mothers were actually delivered and what was the percentage in this. So the incidence that we found about this COVID positive babies in our institute was 6.3%. And overall also, if you find all the articles, they do give an incidence of around 6 to 10%. So I think
So it
it
is
does not say that it is a very high, very much higher. But in the US, if you see, then they had separate isolation areas where they would keep it in the incubators. So their rates were zero positive babies is what they had found in one of the studies which was published by Salvatore. But if you have to see about Sion Hospital, about the Indian scenario, which is not going to happen where you can find a different isolate areas. So it is better that both of them get bedded in. Despite the fact that babies may acquire the infection, they remain to be asymptomatic. So we do have positive encouraging results.
Thank you so much, Dr. Taslima. And it was
Thank
a
you, sir.
wonderful time spent with you on this Saturday evening.
Thank you, sir.
And we will catch up with you soon. Presently, there are no questions being asked, but that's what we thought we should answer on behalf of the delegates who have been there with us.
Thank you, sir.
Thank you. Now we go ahead to the most important topic, which is the highlight of today. And when you have mothers who unfortunately become serious, and it has happened in pandemic times last year, probably now the severity of the disease is less, and we have learned by what the drugs to be given, and as a result, we have patients to be monitored in ICCU, in IRCU, in MICU, and it's an unfortunate thing that when they land up in such situation, we have the best people to handle such intensive care management. I'm sure all of us might have gone through this, and it's very important that it is a multidisciplinary approach, and you need to have an intensivist who is going to take care of your patients who unfortunately turn bad. So I would like to welcome now Dr. Gunjan Chanchalani. She is an intensive care specialist attached to St. Elizabeth Hospital. She has recently been awarded the fellowship of the critical care medicine, and in spite of her valuable, tight schedule and valuable time, she's been there with us. She has authored many books and a teacher for the ISCCM critical care courses. She has been invited as national and international faculty for various conferences and has written chapters and papers in multiple books. I would request her now to take over and the proceedings of this lecture. And if you have any questions, please put them in the chat box and we will be happy to answer them. So, welcome, Dr. Gunjan Chanchalani. Nice to see
Thank you,
you after a
sir.
long time.
Thank you, sir. Thank you for a warm welcome and for the kind introduction. I'll just share my screen first. I want to once again thank Foxy for inviting me to a talk on mother management, because it's Elizabeth actually is more of pregnancy. They have a lot of obstetrics and I really enjoy managing there. So my topic for today is management of critical COVID-19 mother. So I will just take you through a small complete spectrum of illness that a mother pregnant COVID-19 mother could have, and about the management of the same. So if you see as such, in pregnancy, there are not many respiratory failures, or hardly 0.1 or 0.2% of the pregnant ladies actually require mechanical ventilator support. But COVID-19 has been a new challenge in pregnancy, with increasing the number of pregnant patients who require ventilator support. So if you actually have a brief look at the epidemiology, pregnant women are more likely to need ICU admission compared to non-pregnant women of the same age and pregnant women without COVID-19. And there are main risk factors that are there which would lead to severe COVID-19 is if they are more than 35 years, if they are obese, hypertensive, or if they have pre-existing diabetes, of which obesity is the most high risk, I would say, amongst these. But if you see, we still have a good, need not be scared, and we do still have a good promise to the whole thing. Though in this systemic review of 11,000 pregnant women that they studied, at least 50% of them, half of them had pneumonia, and at least one third of them required oxygen by cannula. But if you see, despite the severity of 3% requiring invasive ventilation, only 0.6% died. So that is actually quite reassuring. In this another study with almost 2,500 COVID positive pregnancies, this studied only severe pregnancy patients. And this is mainly if you see in Philadelphia and in France. In Philadelphia, they included 64 patients, and 64 out of 64 were actually with severe disease. And if you see, none of them died. There was zero mortality. And in France, almost 617 pregnant patients with COVID positive status they had included, of which one third were of severe disease, and only one of them actually died. So actually the data is quite reassuring, and we need not really be skeptical or apprehensive about the severity and the mortality. So the risk of iatrogenic preterm birth and cesarean delivery definitely is more. And again, I have used the word iatrogenic because it is mainly apprehension of the treating medical faculty who's actually apprehensive about how the transmission would be or what would be the further course of the illness, is what they go ahead with the earlier cesarean section. The available evidence, as I said, is reassuring, suggesting that maternal morbidity is similar to that of the women of reproductive age, and vertical transmission, as Dr. Nozer also said, is still not very clear. But even if it happens, it is in a very small proportion of the cases. So if you see the main symptoms of the disease, fever, cough, and shortness of breath, these are the main three symptoms with which the patients actually present with. And this is more commonly seen in the black ethnicity, and that is our Asian ethnicity, mainly with obesity. And severity is obviously more common in pregnant patients who are mainly in their third trimester. Complications again can be varied. They can have bacterial or viral co-infection. Maternal, they may require oxygen support. They may require mechanical ventilation, ECMO, and again death. Here again in this study, the death was almost 0.9%. So to understand actually why COVID-19 can have effect on pregnancy, or why what we need to really, how do we nearly treat it, we need to actually understand two main things with it. One is maternal physiological changes that a mother goes through during pregnancy. Again, these changes are mainly two. They are functional physiological changes and anatomic changes. So with these changes, actually there is almost 33% increase in oxygen consumption, 45% increase in cardiac output. There is increased mechanical ventilation with a mild metabolic respiratory alkalosis that happens with a fall in the PaCO2. But despite all these factors, the reserves of oxygen actually are low. The functional residual capacity decreases because of the increasing content of the abdominal cavity. The diaphragm is pushed up. So actually the reserves of oxygen come down by decreasing the functional residual capacity and decreasing the chest wall compliance. So the reserves fall, but the oxygen demands have increased as the consumption, as we have seen, has gone up by almost 1/3. And understanding the fetal oxygen transport, if you see, the determinants of mainly uterine oxygen delivery depend on what is the mother's oxygen PaO2, that is a dissolved oxygen that is there, how much is the hemoglobin concentration and the saturation. The respiratory alkalosis that a mother has because of pregnancy causes the leftward shift of the dissociation curve, of the hemoglobin dissociation curve, that decreases the delivery of oxygen into the uterus. And another factors which it depends upon is the cardiac output and the uterine arterial blood flow. So obviously, if there is hypotension or increased endogenous stimulation, this would all lead to a drop in uterine oxygen delivery. So the clinical features of respiratory failure are similar to what any other non-pregnant female of the same age would have. The main complaint with severity is dyspnea, wherein they are breathless, using accessory muscles of respiration and unable to speak in complete sentences. They tend to take faster and shallow breaths with shorter tidal volumes. They may be confused or somnolent depending on their saturation, or at times may be agitated with sweating, and even may cyanotic if they are presenting very late. If you auscultate them, which is of course a very far-fetched thing with the PPE that we wear these days, but auscultatory findings are mainly the crackles that we hear bilaterally. So the symptoms are same as an acute respiratory distress with which any other patient would have. The laboratory findings, again, many things would be with overlap with what a pregnancy-related disorders would have. Like leukocytosis is quite common in pregnancy, but actually in COVID there is lymphopenia. So almost 34% of the patient have lymphopenia, and raised D-dimer and raised CRP or procalcitonin are quite specific for our COVID-19 disease. But again, even in PIH or eclampsia, you may have similar findings. So we have to consider the whole clinical scenario in place before coming down to a diagnosis of COVID-19 disease. For managing a patient of COVID-19 in the setting of pregnancy, again, we should clearly remember, or we should have this in our mind etched, that any effective treatment which is there for COVID-19 should not be withheld from the pregnant patient because of the concerns of the safety in pregnancy. Because if the mother deserves this, as we all say, that mother is our more primary person of primary priority that is there for treatment. So no effective treatment, if it is considered to be effective for the pregnant mother, we should definitely not withhold it. So decisions which we use, as we know that many drugs during this COVID pandemic were used mainly on investigational level or maybe for trial level. So if any of these drugs are being used for the pregnant mother as a last resort, it should be a shared decision making between the patient and the clinical team, explaining them the details of the safety of the medication for the woman as well as the fetus, and also the severity of the maternal disease. So management mainly includes the medical management, monitoring of the fetus and the uterine concentration, which based on the gestational age, which definitely depends on the obstetrician involved, and the individual delivery planning as per the gestational age. And as you already said, it has to be a multi-speciality team-based approach, which should include a consultation with an obstetrician, a maternal fetal medicine, an infectious disease specialist, a pulmonary and critical care specialist, and also a neonatologist as appropriate. So the goals of oxygen, which Dr. Nozar already mentioned, oxygen is to have a reasonable oxygen level of more than 94 to 95%, which will optimize the fetal oxygen delivery. And to achieve this, if we do a ABG, we should have a PaO2 of more than 70 millimeters of mercury, which almost corresponds to the same oxyhemoglobin level of saturation. So the initial evaluation when a patient with critical COVID-19 or a pregnant patient with critical COVID-19 presents to us is first focus is on maintaining the oxygenation and stabilization of the patient, while we simultaneously take a brief history and a physical examination to determine the cause. If there is mild hypoxemia, an administration via nasal cannula may suffice, but if there is severe hypoxemia, there may be need for a face mask or a high flow nasal cannula or a non-rebreather mask. Usually, a non-invasive ventilation is with a little risk in pregnant in mainly the third trimester because of the uh, increased intra-abdominal pressure, which increases the regurgitation and aspiration during the NIV. So we usually avoid non-invasive ventilation in pregnant patients. Oxygen should be closely monitored with use of pulse oximetry. And as I said, if the patient is critical, our focus should be mainly on ABC, that is on airway, breathing, and circulation of the mother. So medical treatment again is very limited. Only mainly 3 drugs are which are mainly important for the treatment of COVID-19 patients, though there are many drugs which have been researched. Till date, trials have focused mainly on the use of antiviral, which is remdesivir, on steroids, and on anticoagulation. The data or the evidence keep changing every day, and we try to be as much updated as we can. But remdesivir is mainly the antiviral of choice in patients who have moderately severe disease. So in patients who have hospitalized, who are with severe disease or whom you expect to worsen, having high grade fever, but they are not yet on oxygen, we usually suggest using remdesivir if it is available. No steroid should be used if the patient is not on oxygen. Steroid should only be started if the patient is on oxygen support. So in patients who are moderately severe, not requiring oxygen support, and you expect them to worsen because of their risk factors, we would use only an antiviral, which is mainly remdesivir. For hospitalized patients who have severe disease and who are receiving supplemental oxygen, we would always add a low dose dexamethasone or any other glucocorticoid which is available in addition to the remdesivir. For patients who are having severe disease, who have already been on mechanical ventilation or requiring non-invasive support or high flow nasal cannula or already on ECMO, in these cases, if only thing that works is a dexamethasone or any other glucocorticoid. In these patients, usually remdesivir does not work. So starting remdesivir in these patients, in fact, we have lost the time. So that does not really serve the purpose. But if we want to give them the best chance, many clinicians do believe in adding remdesivir as well for a very short period of time, although the clinical benefit is quite uncertain in this late presentation of the disease. For the steroids, if the patient is near term, and we all always use dexamethasone for fetal maturation, we can start 4 doses of 6 milligram IV 12 hours apart, and this may be continued further for up to 10 days or until discharge, whichever is shorter in patients who are requiring low oxygen. For fever, again, we can give NSAIDs, but again, NSAIDs have been found to be harmful in COVID-19. So acetaminophen is the preferred antipyretic and analgesic agent of choice in these conditions. For anticoagulation, again, was again, the evidence kept changing repeatedly. Initially, there was a high demand of using full dose of anticoagulation or a therapeutic dose of anticoagulation, but the latest trials again talk of using only prophylactic dose unless there is any evidence of having any pulmonary embolism or a DVT or a clot anywhere. So it is shown that COVID-19 actually is a prothrombotic state, and pregnancy also being a prothrombotic state, it may increase the chances of clotting in these patients. So every hospitalized pregnant patient with COVID-19 deserves a prophylactic dose of anticoagulation. And if the patient is near term, unfractionated heparin is usually preferred rather than a low molecular weight heparin because it is easily reversible. For pregnant patients who still have few weeks to deliver or a few days to deliver, a low molecular weight heparin, a prophylactic dose can be reasonable, which is up to 40 milligrams subcutaneous daily. And in patients in whom pharmacological prophylaxis is contraindicated, or intermittent pneumatic compression device should be definitely put. Though these drugs we have been using by and large, none of these drugs have shown any convincing evidence. Convalescent plasma has been used on trial basis. And in fact, in severe disease, as a last resort, many clinicians have been using it in India. But again, there is no convincing evidence to use it. About interleukin-6 inhibitors, we have tocilizumab and itolizumab in India, of which these drugs have very fluctuating evidence. Some studies do show they are advantageous, but some do not show any advantage with these drugs. So in patients who are very severely ill and who present to us like very breathless and with a rapid worsening of the disease, we have tried tocilizumab, with which showing positive results in some of the patients. But again, it should be tried only when the patient's present to your, or only on the first 24 hours of presentation. If it is tried at a later stage, or once the patient is on the ventilator for 7 to 8 days or so, then these actually just suppress the immunity with increasing the chances of secondary infection. So they should be avoided at a later stage. HCQ, though propagated a lot by our own government, it has no convincing evidence to be used either as prophylaxis, neither as therapeutic. And the anti-HIV drug lopinavir ritonavir again has shown no convincing evidence of having effect in COVID-19. If there is ARDS in pregnancy, the treatment actually remains same as would be for a non-pregnant female. We usually follow a lung protective strategy for ventilation, which is the ARDS-NET protocol, in which we give low tidal volume for ventilation, which is up to 6 milligram per kg of ideal body weight. It is not the real body weight, it is the ideal body weight of the patient, which depends on the height of the patient. We allow a permissive hypercapnia because of the low tidal volumes that we give. The purpose of providing low tidal volumes is mainly to give the lung a little rest and allow the healing of the lungs. So there is permissive hypercapnia. We allow a permissive hypercapnia with a pH of more than 7.25, which is acceptable, though the physiology of pregnancy demands the patient to be a little more alkalotic. A pH of more than 7.25 is acceptable. Use of neuromuscular blocking agents. There are no studies which contraindicate their use in pregnant patients. Again, there are two trials for this. The Accurus trial, which is in the favor of using very high levels of neuromuscular blocking agents, whereas the Rose trial says there is no need of neuromuscular blocking agents if the patients are well sedated. So if required, if the ventilation demands it, we should definitely use a neuromuscular blocking agents, because again, our priority is to heal the lungs. So positioning in pregnancy is what is the biggest challenge which is there. As we have been hearing since the beginning of this COVID pandemic, proning is what has shown to improve the oxygenation in these patients. Whether it is patient is ventilated or the patient is awake, proning definitely helps. So use of prone positioning in third trimester has been highly challenging, but there are many case reports which have shown that it is possible with use of bolsters and silicone pads to prone them, taking care not to compress the uterine cavity and not to compress the uterine blood flow. So during any maternal critical illness, obstetric consultation is warranted to assist close fetal monitoring, a decision making regarding the correct timing of delivery, or whether it is safe to continue the pregnancy. As per the recommendations that I saw, it is correct to measure and record fetal heart rate tracing daily to assess the to assess the umbilical artery blood flow by a Doppler at least weekly, and to assess the fetal growth by fetal sonography every 2 weeks. I'm not a master in this. This is the recommendation which we usually follow. About ECMO and pregnant patients, yes, ECMO has been initiated in some pregnant patients during pregnancy and also during childbirth, and it was seen that at least 60% of mothers and fetuses survived, though this ECMO was really used only as a salvage therapy during the pregnant and the intrapartum women. So ECMO does has a potential to increase the survival rate of both the mother and the fetus, and should be considered as salvage therapy in patients whom you know that the patient may be reversible. There are multiple complications, as I already mentioned. The complications with the respiration is mainly a severe ARDS, which can lead to complete fibrosis of the lungs and a long-term oxygen dependence. There can be cardiac disorders with very significant level of myocarditis with a fallen ejection fraction. We have also seen patients having coronary artery disease, or rather I would say non-obstructive myocardial infarction. Thromboembolic complications are highly common in pregnancy. As I already mentioned, pregnancy is a prothrombotic state. Secondary infections are known mainly in the second week of therapy because of the high steroids that we use. And in this, again, if long-term steroids are used in many patients, then mucor is seen to be highly common. Acute kidney failure has been seen to be commonly. Neurological disorders and cutaneous disorders have seen. Psychiatric illness is also very commonly known, which is mainly anxiety, depressive, insomnia disorders, and PTSD in these patients. So the newborn outcome, we have already discussed a lot about this, and I will not go into detail of this, but even with the severity of this disease, it has been seen that the risk of miscarriage is actually not increased, though a proportion of preterm and cesarean delivery rates have been increased significantly. And as I said, these increase mainly in the third trimester, mainly because of the apprehension by the treating faculty that is there, treating clinicians which are there, who prefer to deliver the mother electively by cesarean section, because mainly because of the bias to intervene, and maybe because we are more apprehensive that she may worsen in the coming week. So if we find that the fetus is mature, mainly about 32 to 34 weeks of gestation, we prefer to go ahead with the delivery. So outcome with severity of the maternal disease, it was seen that though 9 of them had severe disease and 13 had critical disease out of total 64 patients that were there, because of the maternal status, only while because only 9 or only 22 of these 64 patients were delivered because of the maternal status, and only 3 had to be delivered because of the fetal status. Again, frequency of congenital infection is not known, not very the extent is quite unclear, but probably it is very minimal if it really exists. We really do not know of any case. So when to deliver, again, not my prerogative, but I would just say that the timing of delivery mainly depends on what the maternal status is. Is she expected to worsen, or is she expected to get better with the disease, with the treatment that we have started? What are the concurrent disorders? If there are multiple comorbidities, we would always prefer to deliver with the high risk that the mother carries. What is the gestational age and the safety of the fetus that is there? And of course, it has to be a shared decision making with the obstetrician and the neonatologist and the critical care physician, that is physician. So if the patient is more than 34 weeks, it is easier to deliver, or it is safer to deliver, because we expect the child to be more mature. But if it is less than 34 weeks and the patient is severe, most authorities do not advocate delivery prior to that, because the mother may, though the mother may worsen, the morbidity and the mortality of very preterm infants is very high. So we really do not advocate to go ahead with the delivery. Again, as I said, I'm not a very master in this, so I would not comment more details about this. In patients who are intubated, if the patient is after 32 to 34 weeks of gestation, many advocate delivering the patient if she is stable, and to avoid any pregnancy related problems if the maternal condition subsequently deteriorates. But the delivery itself could exacerbate the maternal condition. Others say that you should consider delivery only for patients if they have refractory hypoxemic failure, or if they have worsening critical illness. As I said earlier, if the gestational age is less than 30 to 35 weeks, if the condition remains stable, it is best to continue pregnancy with a close watch. Or if it is severe, we should probably consider the difficulty of having a very low birth baby that is there. So to conclude, to treat a critically ill pregnant COVID positive mother, we need to have a multidisciplinary team and a shared decision making between the team members, which mainly involves an obstetrician, a maternal fetal medicine specialist, a critical care specialist, and a neonatologist, and if required, also an infectious disease specialist. Any potentially effective treatment for COVID-19 should not be withheld from the pregnant woman just because of the theoretical concerns that are there to the safety of these agents in pregnancy. Decisions regarding the use of drugs approved for other indications or investigational drugs that are being used in COVID-19, these decisions should always be taken with a shared consent with the patient and the patient family, as well as the clinical team, which our priority mainly being the pregnant woman and the fetus, and also depending on the severity of the maternal disease. Thank you so much.
Thank you, Gunjan. It was a wonderful presentation which you have taken us through the multidisciplinary approach and how to start. You have also told the use of low molecular weight heparin, the use of dexamethasone, the remdesivir, and the newer drugs which are available. But obviously, you have also specified that HCQ has got no role to be given prophylactically or for even during this treatment. I'm sure you had a lot of experience of treating such cases who were moribund and they were really bad and they have gone home. So, would you like to share some experiences on follow up and how is their lung compliance following delivery, or they have delivered now because they have there is one term which is known as long haulers, or those who are coming with COVID-19 post COVID-19 syndrome, which also involves the fibrosis of the lung, or later on they have some platelet issues. So can you just share that experience too?
Yes, definitely, sir. Actually, we got wiser with every passing day when we had COVID. So initially, when the COVID pandemic started, we were kind of skeptical about intubating them. We were worried, and people would say once you intubate them, the patient really doesn't survive. So we were trying to maintain them mainly on oxygen support, allowing awake proning and non-invasive ventilation, high flow nasal cannula, and all other measures that would there except intubation. And we had a very high mortality. Only during the mid of pandemic we would say that we realized that when we are actually keeping this patient on a very long time without the ventilation, we are really exhausting them. So when we started, rather we would say it was a by chance that we realized, or we saw little case reports that came in discussing with our colleagues in the different hospitals, that early intubation was actually the main game changer. So now after the mid pandemic, we started intubating early, and we also started extubating them a little early. So we would not really meet the complete extubation criteria, but we would not let the patient exhaust and then put them on the ventilator, because if they exhaust, we would actually lose them. They have lost all the energy to fight it further. So early intubation and extubating a little prior than they meeting the extubation criteria improved our survival drastically. We had lot of extubations, I mean not even tracheostomies, we had extubations by day 5 or day 6 of intubation, and our survival really turned around after that. So that was the main game changer. And of course the another game changer was understanding the role of steroids. So steroids, of course the dose, there is a lot of confusion. Some clinicians use a different dose, so I really did not comment on the dose per se. In UK, the recovery trial talks of using dexamethasone, which is 6 to 8 milligram. But honestly, we use a little higher in our clinical practice. We do not use as low. We prefer to use solumedrol or rather methylprednisolone over dexamethasone, because there are again some reports which say dexamethasone reacts with remdesivir to a certain extent. So we prefer to use methylprednisolone in our daily practice. So with using steroids at the right time, with using remdesivir at the right time, and of course intubating them early, these were the things which really changed our survival towards the mid or the end of the pandemic. So you could say we are in a way kind of quite prepared for the second wave, because we have got wiser with the end of it, but we are still hoping that we don't have a second wave really for the of COVID. I mean, we are really scared about it. But yes, we have learned a lot of lessons, and we would say that it is better to intubate them early and better to start treatment early.
Regarding the follow-up of such patients with lung fibrosis.
So follow-up, again, as I said, if patients were intubated early, these patients surprisingly did not require long-term oxygen, and they did not even have fibrosis. So if you go to ARDS, if you go into the depth of reading ARDS, they actually say giving rest to the lung. So the lung which is there or which is damaged, the alveoli membrane which is inflamed. So if you allow them a little rest, they recover very fast. So in those cases in whom we intubated early, I do not have any data per se, but I can clearly say we saw their oxygens go off by the second week end. I mean, end of the second week. So we saw them by the 10th or 12th day, they were totally off oxygen. But in patients whom we prolonged them on non-invasive support, or we prolonged them on, you could say on AirVo, which was high flow nasal cannula, these people landed up in fibrosis. So if you read further, you see there is a new term which has come up, which is like patient self-inflicted lung injury. So when we talk of lung injury in ARDS or on ventilator, there are multiple terminologies. One is volume induced lung injury or ventilator induced lung injury. One is pressure induced lung injury. One is the biotrauma, that means because of the inflammatory markers that are there is a lung injury. And there is one which is called as atelectotrauma, that is because the alveoli tend to close completely, they don't open again, they are like balloons. So that also is a kind of lung injury. But this COVID pandemic has given us a new terminology, which is PSILI, which is patient self-inflicted lung injury. So because they do not have adequate oxygen, they tend to take a very large deep breaths and they are tachypneic. So that does not really give them their lung any rest. So they tend to damage their own lungs with each tachypneic breath that they are taking, or the air hunger kind of breath that they are taking, generating a lot of intrapulmonary pressure or negative pressure in the lungs. So this actually increased the fibrosis in patients whom we did not ventilate early. And this was more commonly seen in patients who required non-invasive ventilator, because with non-invasive ventilator, we tend to give them more PEEP or more pressure support, which allowed them to take larger tidal volumes. So that caused more injury to the lungs. So this self-inflicted lung injury patients definitely landed up with the fibrosis, but fortunately, many of them could go off their oxygen by the end of 6 to 8 weeks, you could say. And some were, you could say, lifelong dependent on their low oxygen support at home. We still have patients who are like 4-5 months of COVID, cured of COVID, but they still require oxygen. And if you actually speak to them, because we do a lot of video consultation with them, they cannot complete sentences even till today. Walking to the bathroom is a challenge for them. So they have landed up with a complete impairment of their physiology or their daily or their quality of life, you could say. But there was no screening marker which could tell us that they could, this patient would land up with a fibrosis or a poor quality of life, so that we would not go aggressive for this. Like if somebody is with a malignancy, we usually counsel them not to, you would have a bad quality of life or you don't go ahead with this. But unfortunately in COVID we do not have any such scale or any such scoring which would warn us about this. So we went aggressive for all, and some, definitely I would say not many, but you could say up to 2 to 3% of the patients are on long term oxygen therapy even after 4 to 5 months of their illness or their recovery from COVID-19.
Thank you, Dr. Gunjan. We also saw the slide which you have showed, the meta-analysis and the review of literature done by Dr. Asma Khalil and Pat O'Brien from University of London, and we are very proud to say that they are part of our panel of TOG webinars,
That's
and
correct.
they usually come to India virtually every 2 to 3 months. And I want to share with you one more thing, that today we have broken all the records. Presently we are probably in the just the beginning of the second wave, or I hope it doesn't come, but the record is such that we have during this time, as the COVID pandemic has also gone over a period of time, the viewers of webinars have gone down over a period of time. But I would
Yes.
like to tell you that today being a Saturday and being a weekend, we have crossed more than 550 members live who are present on a weekend, which is a very big number as compared to 150 or sometimes just 200 members. So it's really very interesting that many obstetricians who are there, and of course once it goes recording on YouTube channel of Science Integra, it will be seen by more than 2,500 members. So your take on critical care management of obstetric patients was very nicely explained, and the experience which you had at St. Elizabeth, uh, it's amazing to hear from you. I would like to hand over the mic to Dr. Komal Chavan, but before that, I want to uh, ask you regarding the prone position of patients to be kept when they are in ICU, and if they are, say, in the third trimester, how would you, means you would prefer to them to lie them in the left lateral position, or so that can you just elaborate on that issue from
Yes, sir.
obstetrician's point of view?
Yes. So the proning, as I said, is a huge challenge in patients, in pregnant patients mainly, and in fact in obese also. We had many obese patients who were actually landing up in severe disease. So they also required, and it was a challenge for us. So in those patients, we actually use a lot of bolsters and pillows, you could say, so that the abdominal cavity was free. So we would make sure that there is no compression. But then again, if the patient is awake, they do not cooperate with lying on pillows, and it's quite uncomfortable, causing a backache. So we would allow them to take the position they want, and we would advise them to change position every 30 minutes to 2 hours. So minimum 30 minutes they have to lie in a lateral position which they wish, which can be completely lateral, or you could say semi-prone kind of a position where they are not really lateral, not really prone, which can be. I do not have. I should have put a picture, but unfortunately I did not. So those position is what many patients found comfortable, and even pregnant patients would prefer being in a lateral position, because again they were skeptical about compressing the uterus. In fact, I saw a first trimester pregnant female also. Not, you could not say first trimester, but she was around the 14 weeks with really not a very big uterine cavity or a uterus to be palpated. But then, if I would ask her to lie prone, she was very skeptical about going prone, and all she wanted was to be lateral. So all we advise them is you change position every 2 hours, so at least some amount of lung alveoli which can open up with every change of position. So we allow them to take position as they want, but we avoid them to be in supine for more than 2 hours at a time, or more 30 minutes to 2 hours at a time. And we ask them to change position every alternately, right lateral to left lateral, so both the lungs are equally benefited. So prone positioning, actually, though it is since 2007, we are seeing a lot of studies which is talking of prone position in ARDS. In COVID pandemic, it has, actually gained a lot of mileage or importance, you could say. That is because during this pandemic, there was a great shortage of ventilation, and that was a time when the awake proning, they started putting the patients prone awake itself without putting them on the ventilator, and they saw that the oxygenation improved significantly. So this actually happened because they were short of ventilation. So actually, we need more studies now in normal ARDS, that is non-COVID ARDS, to understand whether awake proning would help those patients also. So proning in the third trimester, of course, if the patient is awake, she would never go for a prone position. So we advise them to go lateral alternately. But if the patient is in the third trimester and is ventilated and sedated, we put a lot of bolsters and pillows to make sure that the abdominal cavity is not at all compressed. And of course, we do a lot of monitoring of the fetal heart rate to assure that we are not compressing the uterine cavity. So you could, though I have mentioned about fetal heart rate monitoring even only once, we actually did it 1 hourly initially. When the patient gets home, we would do it almost 15-20 minutes to make sure that everything. I've seen only actually one patient who was not really in the you could say near term, but she was around 29 to 30 weeks of pregnancy. So we actually monitored the fetal heart rate every 15-20 minutes to uh, to see the fetal.
So, did she underwent a normal delivery or a cesarean section?
So
Or
I did
how?
not follow up with that, but she did survive. She did survive. The baby was fine at the end of it, Eva, and she did survive the whole episode. I will definitely follow up on this fact that is there.
Absolutely, that was quite heartening to hear that she has survived. Thank you so much. I would like to hand over the mic to the chairperson, Dr. Komal Chavan, to conclude this talk and take over from me.
Yeah, thank you so much, Dr. Gunjan. I think you are speaking with the first-hand experience of something which we dread about COVID, that is the complications and managing the high-risk patients when they require this, the HDU care that is the most wanted. And in this COVID time, everybody is now getting aware and knowing that how important this ICU care and ventilation and support, life support, which we offer to our patient. And definitely when it comes to pregnant patient, this becomes of more and more importance. So you have spoken so well and excellently covered everything, and very informative talk with all your first-hand experiences. And this brings to the end of our whole circle webinar tackling the maternal as well as the fetal and the intensive care aspect about the COVID-19 in obstetrics. And definitely I thank Dr. Nozer Sheria, Dr. Taslima, Dr. Gunjan, who have done full justice to the topics with a very apt, practical take-home messages for all our viewers. And Dr. Niranjan Chavan, who has moderated the session so beautifully, bringing out all the practical points and making the discussion go ahead in a very superb manner. So I thank all of you for being the part of this webinar on a Saturday evening and sharing knowledge to our colleagues in this time of pandemic. And definitely we all hope that we don't have a second wave and no atypical or no variant or mutants of COVID. So we all pray for all good health of everybody. And I thank with a note, thanks to Science Integra, TOG and MCure for bringing us on this platform. Thank you so much from Foxy Medical Disorders in Pregnancy Committee. Thank you. Stay safe.
Thank you, ma'am. Thank you, sir.
Thank you so much.
Thank you. Thank you.
Thank you, doctors.